incoming. So thank you so much for inviting me to talk in these pediatric masterclasses about food allergies. And what I hope to talk about today, just a minute, this is not moving. Okay, today what I want to talk about is food allergy in Sri Lanka. And of course, there's a topic given as food allergy in Sri Lanka. So whether it is a problem. And most importantly, what is a food allergy and what is not, and why it is important to know that. And if all food allergies are the same, and finally, a bit about diagnosis. Now, I think all of you are aware that food allergy is an important problem globally. So this is just data from the US, where 32 million Americans have food allergies. That's a large number. And 1 in 10 adults and 1 in 13 children have food allergies. And the proportion of food allergies resulting in anaphylaxis from 2007 to 2016 has increased by 377%. So that's in America. And all of you as pediatricians and trainees in pediatrics know that, especially children, they start off with, they have this so-called allergy march, where they start off as atopic eczema, then get food allergies, then have wheezing and asthma. And as they grow older, they overcome, most of them overcome the eczema, food allergies, and instead have allergic rhinitis or asthma in adults. So this is what happens in most other countries, but it's the same in Sri Lanka. So there is no doubt when you look at all the evidence that the food allergies are on the rise globally, but what about Sri Lanka? So to highlight that, I thought I'll just tell you this story of a child who came to see me some time ago. And this child was from Malavige. By the time the child came to see me, the child was in grade 1, but had been out of school for 6 months. And the reason is, so this child was known to have a food, cow's milk allergy from childhood. Basically, since the child was like 10 months, 11 months old, the parents were aware that the child got a reaction to cow's milk and were very careful. So the parents were vegetable farmers coming from a very poor background in the Malavige area. And then after the child was admitted to school, grade 1, there was this SIL program or some program like that, where children were given food not brought from home. And this child had taken 1 mouthful of a yogurt and developed anaphylaxis. So had been rushed from one hospital to the other, finally ended up in Nuvareli hospital. And after all the treatment was given and the child's life saved, when the parents took the child back to school, the school principal has said, do not bring the child back to school unless it is cured. So this is so they had gone from one doctor to another to get this cow's milk allergy cured, and unfortunately had missed school for 6 months. So this just not highlights that, okay, even that you do have food allergies even in the poorest families in the most remotest areas in Sri Lanka, but how much allergies are neglected disease, and how there is lack of awareness in schools, not just in remote areas, but even in Colombo, how much there is lack of awareness in among adults, in schools, parents, and how much children suffer because of that. So food allergy is a problem in Sri Lanka. And coming to the next question, different countries consume different type of food. And of course, all of you would have heard that peanut allergy, nut allergies are very frequent in the West. They have a very different diet. We have a different diet, and in the Southeast Asia, they have a different diet. So are food allergies specific to different countries? Do we have things like peanut allergy? If not, what type of allergies do we have? And how do these allergies, food allergies, differ from country to country? Because I think it's important to know when kids come to you to understand what are the most likely food allergies they're likely to suffer from. So this is one global study, which is a systematic review of a global study. And as you can see here, the predominant allergens causing food allergy are very different from country to country. However, there are particular allergens which are common to all countries. So for instance, if you take something like peanut, which is an important cause of allergy in South Africa, in Europe, and in North America, it is not an issue in Sri Lanka, Taiwan, and Thailand. You see, South Asian, Southeast Asian countries. But if you take something like cow's milk, it is a significant problem in Sri Lanka, in Japan, in Europe, and so many other countries, but lesser of a problem in North America and Australia compared to peanut. So yes, food allergies differ, and this depends on weaning practices, the type of other food that are introduced, and things like birds, and of course food consumption. For instance, things like bird's nest, which is an important allergen in Southeast Asia, is unheard of in Sri Lanka because, of course, we don't consume it. And so these are the predominant allergens globally, and you can see the geographical areas where these allergens are present. So peanut is a huge problem in North America, Australia, and Europe, and of course not in Africa and Asia. Cow's milk is present in so many countries, including Latin America, Russia, and you can see Sri Lanka. Egg, again, in different regions. Then you have seafood, and so on. So these main 8 allergies, or we call these the big 8, have very varied geographical regions, and also there is a difference in the type of food allergies in adults and in children based on the region. So for instance, crustaceans are the #1 allergens in Europe in adults, and in Asia in adults and children, whereas in European children, the #1 was peanut. Now coming to Sri Lanka, we have a different allergy pattern, food allergy pattern, and this is a study done by along with Dr. Rajiva, with his patients and our patients put together. And so this is a different age group. So this is 1 to 5 years. This age group is 5 to 19 years, and these are adult age groups. So you can see in children, 1 to 5 and 5 to 19, food is an important cause of anaphylaxis. In very young children, there's an important, vaccines are also important cause, but I think because these are tertiary referral centers, immunology clinics in Colombo, it over-represents vaccine allergy. But when you look at the food allergies that mainly cause anaphylaxis in Sri Lanka, beef and cow's milk are #1. And this surprised a lot of people in other countries that beef is a #1 food allergy because, for instance, beef allergy is extremely rare in Europe, North America, and even in Southeast Asia, where beef is consumed quite a lot. So the reason why we have beef allergy as one of the #1 allergens, we don't know. It could be even in individuals who eat beef. Beef is not given in the so-called gastric tolerance window, and it's delayed. So delay in introduction of certain food may also lead to allergies. So these were the main food allergens in Sri Lanka: beef, cow's milk, and the red meat. And the main plant allergens are, of course, things like wheat allergies is huge. You do have lots of wheat allergy, especially in the context of exercise-induced anaphylaxis. Unfortunately, because I need to cover a lot, I can't talk about exercise-induced anaphylaxis today. But the other allergens are things like murunga, sarana, sesame is an important cause. So things like murunga and saran allergy is unheard of or very, very infrequent in other geographical areas, although wheat allergy is very common. Now, coming to the most important question, I think, is to identify what is a food allergy and what is not a food allergy and why it's important. Because children with food allergies suffer a lot, and we don't want to label somebody as having a food allergy if that child actually does not, because then it not only leads to exclusion of these possibly very nutritious food from the diet, it also leads to a lot of really reduction of quality of life, exclusion in school activities. So, for instance, children with multiple food allergies or severe food allergies are sometimes in some schools and nurseries excluded from sporting activities, fun activities, and so on, because the school finds it difficult to handle such children with these very common allergens. So it is important to actually find out and label the children as having allergies if they truly do. And by mislabeling people as having a particular allergy, you might actually miss the true cause of the allergy, and that person might repeatedly go on to have allergies. And a classical example in such instances, exercise-induced wheat allergy, which is very rarely diagnosed, and many other food items are implicated. The child goes on a very exclusion diet, but still goes on to get anaphylaxis because the real cause is not excluded. So it is important to actually identify, first of all, whether the child has a food allergy, and if so, which one it is. Now, I'll give this classical example. I know Professor Janice and Neelika is going to talk about atopic dermatitis, but this is a classic example of a child who came to me, who was a 9-year-old child who had moderate atopic eczema. And of course, her eczema is bothering her because it's quite itching and so on. And also now the girl is 9 years old and it's not cosmetically acceptable. And her dermatologist has advised that she should avoid the following. So she has been asked to avoid all milk products, eggs. Can somebody, there's a background noise, can somebody mute that noise, please? Thank you. Her doctor has advised her to avoid all milk products, eggs, tomatoes, pineapple, tuna, and to only eat white fish, to avoid prawns, cuttlefish, and all types of leaves. And she has been previously eating all this food and has not had any reaction, and she likes to eat this food. So the question is, I hope we can have an interactive session, or at least on Zoom. Should she be avoiding this food? Yes. Okay, so I think I'm unlikely to get any answers. So I mean, children with eczema do have food allergies, but if you can actually find a cause and effect, like somebody eats food and then you get a reaction, you can do the relevant tests and finding out. But apart from that, just avoiding such a large variety of food does lead to nutritional deficiencies and leads to a drastic reduction in the dropping the quality of life. So it's very important. There are guidelines. I've just put here the Nottingham Children's Hospital guidelines. I mean, there are so many different guidelines from different hospitals, different societies. And it's important, while children with atopic dermatitis are more likely to have food allergies, not to just exclude food from the diet unnecessarily without proving that the child is allergic to a particular food. Now it got stuck again. Okay, and I know Dr. Rajiv De Silva is also going to talk on chronic urticaria, but again, because we are talking about what is not a food allergy, just wanted to highlight this child as well. So a 6-year-old child has urticaria appearing mostly in the evenings or early morning for a period of 2 months. She had had similar condition 6 months ago, which only lasted for a week. An antihistamine such as chlorpheniramine does not seem to be very effective. Would avoidance of all animal proteins be beneficial? And is this a food allergy? So lots and lots of children and adults with chronic urticaria are put on allergy avoidance diet. In other words, many children and adults are all asked to avoid all animal proteins. Okay, all types of animal proteins, and also labeled as having a protein allergy. So, and it's very difficult to understand what a protein allergy is, because after all, amino acids are essential for humans. So to avoid all protein allergies, and there are kids who have been on complete avoidance of animal and vegetable protein for months. And so it is important to again realize that chronic urticaria is not because of a food allergy. And there are so many guidelines. Dr. Rajiv will be possibly talking about all these. And so especially acute spontaneous urticaria, which is less than 6 weeks, does not mostly need investigations. And inducible urticaria, which is chronic urticaria, is because of so many other reasons like cold urticaria, delayed pressure urticaria, solar heat, but not because of a food allergy. In chronic urticaria, it is not food allergy testing that is recommended, as you can see, because chronic urticaria is not due to a food allergy, but completely a different set of tests, because the cause of or etiology of chronic urticaria is very, very different. It is not due to a food allergy, and I think that is something that is important to keep in mind. Okay, and also not give long-term systemic steroids, especially for children with chronic urticaria. Now, coming to, okay, then what is a food allergy in that case? It is important that to get certain things right, and that the reproducibility factor being there. And studies have shown that only 25 to 40% of self-reported allergy is actually confirmed as true allergy. And sometimes food allergy is confused with tolerance, and it is important to confirm or rule out allergy before labeling somebody as having a food allergy. So there are certain important clues in the history that would help to identify if somebody has a food allergy or not. So first of all, timing of symptoms in relation to consuming food. So sometimes people come and tell you that somebody ate salmon on Tuesday, and on Friday they got urticaria because of salmon, 3 days later. And of course, you know that after 24 hours or even less, there is no so-called salmon protein left in your body, because everything is, converted or degraded either to different amino acids or urea and, metabolized. So we are talking about type 1 hypersensitive reactions or IgE-mediated reactions. Usually, most of the food allergy symptoms occur within the first 1 or 2 hours. Sometimes it may be delayed to 3-4 hours in the case of exercise-induced wheat-dependent anaphylaxis. Or there is this other red meat-associated allergy called alpha-gal syndrome, where again, you have an allergy to this alpha-gal component in red meat, which can be delayed, and you can have delayed anaphylaxis. Apart from this omega-5 gliadin, which is exercise-induced wheat anaphylaxis or alpha-gal syndrome, all food allergy symptoms occur within 1 or 2 hours after consuming the food. So the timing is very important. Then whether the food was consumed in a raw or cooked form, again, sometimes the child might say that the cooked food can be tolerated, but the raw food cannot, because this is because some allergens are destroyed by cooking, especially heat labile ones. And of course, what type of treatment was given, how long it lasted. Symptoms of food allergies don't last for days. Okay, so you don't have somebody having, somebody had ate pineapple, got urticaria within 1 hour, but that urticaria lasting for 7 days, that is not a food allergy to pineapple. And how severe was the reaction is for prognosis, and whether other factors are involved like NSAIDs, alcohol, and exercise, is because these are co-factors in aggravating allergies. These reduce the threshold of mast cell degranulation. So even with a lower concentration of allergen, the person can have a food allergy, or if the person had a mild food allergy, actually can go into anaphylaxis. So coming to diagnosis, because I think I'm coming to the end of my 20 minutes, the most important test in diagnosis of food allergy is the history. Okay, it's not any of the diagnostic tests. It's not all these fancy blood tests. But to diagnose food allergy, the most important thing is the history. So you have to take a history about the timing and also previous episodes, whether the person tolerated the food before without getting symptoms and all that, and come up with a differential diagnosis and test for those specific allergens. Because in medicine, diagnosis, laboratory diagnosis is about taking a careful history, doing physical examination if relevant, come up with a differential diagnosis and then test, and not just doing these allergy panel tests. So, so there are various types of allergy panel tests in private hospitals which are very expensive, and so for instance, sometimes somebody might have had an allergy because of red meat, let's say beef or pork. The doctor does allergy panel test and the allergy panel test comes negative. Not surprisingly, because beef or pork was not included in that allergy panel. So it's pointless doing panel test, especially when that particular allergen is not included. And so if you're not sure, there are enough and more people, so do ask. And these are the types of tests you can do. You can do skin prick test. For the conventional allergens like cow's milk, egg, wheat, you have commercial extracts which you can put on the skin and make a tiny prick, and you get a wheel and flare reaction. But for local allergens, because we do have patients who are allergic to murunga, sarana, then even things like kalana batu, tip batu, manioka, jackfruit, and a lot of other fruits like jambu, various things. And for those are heat labile. Some of them are heat labile. So we ask the patient to bring the food and do a prick-to-prick test, and so to identify, especially when it comes to local allergens causing, food allergens causing anaphylaxis. Then there are many types of in vitro tests. The gold standard in vitro test is the RAST, now called ImmunoCAP. But apart from that, in private hospitals in Sri Lanka, there are many other types of in vitro tests, which are not very sensitive and not recommended by many of the allergy societies. The ImmunoCAP is the gold standard. And these can also quantify allergens and also apart from testing for specific allergens. But of course, the clinical history is the most important, as I can tell you, show you here. As you know, in medicine, the mere presence of an antibody to anything does not mean that the person has the disease. So you can see this child here is happily eating peanut butter with a peanut-specific Ig of 18.2, whereas this child is having anaphylaxis with peanut-specific Ig of 2.6. So the Ig levels do not correlate with severity among different people. And, you know, antibodies are cross-reactive. So for instance, peanut Ig cross-reacts with a grass pollen called timothy grass. So somebody with allergic rhinitis to timothy grass can have Ig levels to peanut. So that is actually a cross-reactive IgE rather than a specific IgE for peanut. So the most important thing is sensitization does not equal allergic disease. The history is the important thing, and then you correlate with the history. And when you're advising patients, I won't go through this. You can look up this publication to find likelihood of cross-reaction if somebody is, for instance, allergic to peanut, the chances of cross-reacting to other legumes is like 5%. So you don't have to ask the person to avoid. But if somebody is allergic to cow's milk, the chance of being allergic to goat's milk is 92%. I wanted to highlight that because in Sri Lanka, people say, if you have cow's milk allergy, get goat's milk because of this thing. Thing is not a food allergy, but people with kids with true cow's milk allergy, the likelihood of being allergic to goat's milk is 92%, whereas something like horse milk is like 4%. So if somebody wants to drink milk, horse milk would be the way to go. So it's important to realize these things when you're advising people, children, against the likelihood of cross-reacting to another food if they have allergy. So if somebody does have allergy to prawns, for instance, you would ask the child to avoid crab, lobster, and other crustaceans because of the 75% chance of reaction. And coming to the final question, are all food allergens the same? So if somebody is allergic to, let's say, watermelon, is it the same as being allergic to sesame or to cashew nut? We do have cashew nut allergy, by the way. And this is, again, especially when it comes to plant allergens, the heat stability and the protease stability is very different. So in plants, there are 5 different types of protein allergens. And some of these protein allergens are very stable in heat. In other words, they are not destroyed by cooking or by gastric enzymes, whereas some of the plant allergens are very heat labile. So if you cook it, you destroy it and people can eat the cooked form. So for instance, raw celery might cause a reaction, but if you cook it, it's fine. The same with apple, peach, and in Sri Lanka, banana. Some children are allergic to banana, but if ash plantain, which is cooked banana, is fine. And the risk of getting a severe reaction depends on the stability of the protein. So plant proteins, which are heat labile, and protease, susceptible to protease, are less likely to cause severe reactions than the ones that are more stable. And nuts, of course, very stable proteins to heat and protease. And that's why even very nanogram quantities of nuts can cause reactions. So to stop and wrap up, just to take home messages, it is a patient presenting with possible symptoms suggestive of a food allergy. It is important to identify if it is a food allergy or not. History is the most important thing, nothing else but the history. And allergy panels are unlikely to provide accurate information. It might just pick up certain things, cross-reactive allergens that are actually not the cause. And some food allergens are more likely to cause severe allergies than others. Thank you so much.
Thank you, Madam, for that exceptional presentation, which we would have had a little bit more time to listen to you. Professor Neelika Malavige, Professor in Immunology and Molecular Science